Hi there, my name's Alan Winston. I'm a Professor of HIV Medicine at St Mary's Hospital in London and at Imperial College in London. So I'm a clinician. I look after people living with HIV in the outpatient and in the inpatient setting. And I also run several clinical research studies. We mentioned in the plenary, are we sitting on a time bomb? So are things going to get worse and worse and worse for people living with HIV? And are we going to see more and more comorbidities and problems as people age? I think we also have to talk about the reassuring data that the risk factors for these comorbidities are probably changing over time as people with HIV are aging. So we now have when someone is now diagnosed with HIV, they start antiretroviral therapy at a much higher CD4 count if they're in a healthcare system. They start antiretroviral therapy with a much less toxic treatment, and the number of people presenting with AIDS-defining illnesses is a lot lower, thankfully, than in years gone by. So these are all also important risk factors for complications, non-infectious complications. And as these risk factors decline over the next decades, there's also hope that the number of comorbidities or the age of onset of comorbidities in people living with HIV may also go down. So I think there's reassuring data out there as well that a lot of the risk factors with HIV treatments improving will actually decline. Yeah, I think that's completely fundamental, that we have to be working with other healthcare professionals and other researchers with other areas of expertise. So I'm an HIV clinician. I can't do everything myself, and I'm not the best person to see if you want to talk about cancer or how your kidneys are working. So both on the clinical side, it's really important that we work with other specialists. At our centre, at St Mary's, we do joint clinics. So I run a joint HIV neurology clinic with one of the neurologists. So we have the HIV expertise and the neurology expertise. And we do this for many end organs. So we have an HIV renal clinic, we have a metabolic clinic, and that really allows the patients coming through our services to get this joint expertise. I think on the research side, we have been a little slow to engage in this approach, and it's fundamental as well. We are working with geriatricians, with public health physicians and within our network. But yes, we need to be working with researchers from a whole host of different backgrounds. So I think there's several exciting areas to focus research on. So a lot of work regarding HIV dementia or mild cognitive impairment in HIV disease has focused on antiretroviral therapy. And historically, it's focused on not enough drugs getting into the brain to prevent the virus from turning over. I think nowadays with the modern antiretrovirals that we're using, for the main part, most of the treatments that we're using, they do seem to suppress the virus in the nervous system. So the focus is moving a little bit towards, could the drugs actually have some toxicities on the nervous system? Another interesting aspect is the immune system affecting the brain, and could this lead to dementia, mild cognitive impairment? And there's evolving work on biomarkers, so measuring markers from lumbar puncture fluid, and also markers from imaging, from MR and PET scanning, looking at inflammation in the nervous system. Another important aspect are the other peripheral peripheral comorbidities or medical problems outside the brain and the rest of the body, and how they could contribute to brain health and to cognitive function. So we know that heart disease and kidney disease can affect the brain, and there's mounting evidence that these conditions affect the brain in people living with HIV as well. And studies looking at modifying risk factors and treating these peripheral diseases may have implications on brain health and cognitive function.